Good afternoon, everyone. I am Arun Joseph, and I'm a graduate reading for DPhil in Clinical Neurosciences at the University of Oxford at Jesus College. I'm very glad to invite you all to our talk hosted by the Ventilator Weaning and Extubation in Neurocritical Care Network at our Nuffield Department of Clinical Neurosciences. Today's talk is on neurophysiology of human pharyngeal and swallowing function in health and disease states by Professor Shaheen Hamdi. Professor Hamdi is a professor of neurogastroenterology in University of Manchester and has a clinical academic contract with 50% of his time delivering clinical care at the Salford Royal Hospital NHS Trust. He's also the lead academic clinician for the NIHR Integrated Academic Training Program in Gastrointestinal Sciences, and his research has attracted £4 million in external grant incomes. His research interests include neural mechanisms within the gastrointestinal system, with a particular focus on neuroplasticity and functional recovery following brain injury using human swallowing as an experimental model. And this work has provided new knowledge about the cortical control of swallowing in human and defined which aspects of its organization are important for recovery after stroke. So with that introduction, I'll hand you over to our very distinguished guest, Professor Shaheen Hamdi. Thank you.
Thank you, Aaron, and for that introduction. Hopefully everybody can hear me clearly. Today's discussion will perhaps be a little bit different from maybe what you're used to in this arena, in that I'm going to predominantly focus on an area which often gets a little bit ignored, which is understanding the neurophysiological processes involved in swallowing in humans. And it has obviously implications for critical care and swallowing issues in the intensive care environment, particularly with regards to complex patients who have got tracheotomies and require significant ventilatory support, who often will have aspiration and issues around their swallow functions being a reason why they can't be extubated and then sent to lower level care. So we're going to focus mainly on physiology and some neurophysiology and a little bit of pathophysiology. I won't actually talk specifically about tracheotomized patients, but over the course of the talk, hopefully this will help to give you a bit more understanding of why patients may have swallowing difficulties in the first place. So this is a quick overview. We'll talk a bit about the physiology, and I'll talk a bit about what technique that we've used a lot in our lab to look at swallowing. I'll talk a little bit about the problem of dysphagia and one of the models that we've been using, which is in the area of stroke, recovery mechanisms, talk a bit about some of the neurochemical drivers involved in those recovery mechanisms, and then talk a bit about some of these neurostimulation techniques that are being used slowly but surely as novel therapies for rehabilitating swallowing after cerebral injury. And then a little final delve into genetics and plasticity in the swallowing model. So quite a lot to cover. Some of it will be hopefully new to you. With a bit of luck, we'll get through this in about 50 minutes. So I'm sure you'll be aware that the swallowing system is complex, but essential. It involves a very large number of muscles, 31 pairs of muscles and cranial nerves. And this complex semi-reflexive process is typically divided into three stages: the oral phase, the pharyngeal phase, and the esophageal phase. For the purpose of this talk, I will predominantly focus on the pharyngeal phase of swallowing rather than the esophageal phase, because that tends to involve slightly different mechanisms. This just is an example of the fact that we have this kind of temporal process involved, from cortical control through to enteric nervous system control of the swallowing system, and that the muscle groups vary from being striated to smooth, and that the system involves either full, some, or no voluntary control. Although there is a lot of interest around the fact that there may actually be cortical mechanisms involved in even esophageal function. And of course, when we do make a swallow, and this is a video fluoroscopy of a human normal volunteer, really, who's just swallowing barium. And what you can see when we look at it with fluoroscopy is that it's a very quick process. So, the whole action of the swallow from the oral phase right through to the upper esophageal sphincter is literally less than a second. And when we look at the processes involved, you can see that the whole evolution of swallowing on average doesn't take more than about 1.1, 1.2 seconds. So very quick. So it needs to be very well controlled and very well coordinated. And as you can see here, if you look at the area of pharyngeal contraction, that really only takes about half a second or even less. And when these timings of these various functions go wrong, particularly the laryngeal airway closure in association with weak contractions and loss of, for example, tongue thrust, then this will lead to swallowing abnormalities, potential risk of aspiration, and of course, dysphagia with the associated side effects. So back to the neuroanatomy. And as I've already commented, you can see that the swallowing system is a hierarchical system. So we have at the top the cortical control mechanisms, which send inputs to the brainstem, which has the central pattern generator, or CPG. And this integrated system within the brainstem allows the sequential events of swallowing to take place through motor neurons in the bulbar brainstem area, which leads on to the muscles of swallowing and then allows them to contract in a coordinated manner. And through this system, there is feedback occurring from sensory receptors in the oropharynx, larynx, and upper esophagus, which lead back to both the brainstem and to the cortex through these cranial nerves in order to modulate and to either eject or allow the swallow to take place. So it's a very sensitive system. And indeed, if you take away some of this sensory function, for example, if you give anesthesia to somebody through a throat spray, it becomes very difficult for them to perform a motor swallow. And indeed, saliva also acts as a sensory stimulus. And what you'll probably find is that if you attempt to swallow more than about 3 times consecutively, when you lose saliva, it becomes very difficult to swallow, and that's because you're losing some of that sensory stimulation. So talking about sensory stimuli, there are a lot of different stimuli that will activate swallowing, and I show a list of these here. You don't really need to remember this, but just to say that there are a number of sensory receptors within the swallowing system which respond to different inputs, and some of these relate to pressure. Some of these relate to water itself. Some of these relate to hydrogen ions, including sour solutions and carbonation, and some of these relate to thermal stimulation. So all of these different inputs have relevance when it comes to activating the swallow, usually through the superior laryngeal nerve and also the glossopharyngeal nerve. But they are quite important because we sometimes use this information in order to manage patients who've got swallowing difficulty. For example, increasing carbonation or warmth or sourness in fluids, which can help to try and promote a slightly safer swallow. And the central pattern generator itself, which sits within predominantly the medulla and lower pons, is linked through a number of nuclei. We have the nucleus of the tractus solitarius, which is the sensory input system. So the peripheral afferents come through to this nucleus of the tractus solitarius predominantly, which then through interneurons can either go into the supra-bulbar areas, but equally can transfer information to interneurons within the brainstem, which then lead to the output areas, which includes the dorsal vagal nucleus and the nucleus ambiguous, which is predominantly a vagal nucleus, and that then can obviously produce outputs that lead to contractility of the swallowing system. And as I've said, there are inputs coming in as well from superior medullary areas, cortex and subcortex, which influence the nucleus of the tractus solitarius. So both inputs from above and below are relevant in terms of this swallowing system. So quite a complex process. Of course, as I said, there is a cortical system which produces inputs that go from predominantly the lateral areas of the sensory motor cortex, which in humans is considered to be a little bit above the Sylvian-Fisher area in the sensory motor cortical regions, which you can just about make out with this slide, which produces those inputs I've talked about that go to the brainstem. And as you can see from this slide, you also have inputs actually which are likely to come from basal ganglia, thalamus, cerebellum, and the limbic system. All of these have relevance in terms of sensory information and coordination. So we have this really quite interesting hierarchical, multi-dimensional system involved in the control of swallowing. So getting a handle on this process takes a bit of effort, and obviously, and I guess a lot of the audience will be aware that nowadays, into the 20th century and beyond, we've got different modalities that we can apply to human physiology and neurophysiology to study the swallowing system. And we've used quite a few of these in our lab. And I'm going to talk a bit about some of these, including TMS, a little bit about fMRI. I think I may touch on a bit of PET and a little bit of MEG as well. But we've tended to use predominantly whole brain imaging to study the system in more depth, both in health and disease. But if you go back to the 1930s, a Canadian neurosurgeon called Wilder Penfield was probably one of the first people to look at the human control of swallowing. He was the individual who mapped out the motor homunculus, and during his mapping of these patients who had epilepsy, who had their cranium removed, and he was stimulating the motor and sensory cortical areas, amongst some of these functions that he looked at was swallowing and throat sensation. And you can see that he was able to map out the areas that induced either a swallow or a sensory sensation in the throat. And you can see it's quite variable. So it goes quite high up into what might be seen as more sort of neck area of the homunculus, maybe moving even into close to the hand area, to be honest. But majority of it was a little bit lower down in this kind of caudolateral area of the motor and sensory strip. Of course, now we don't need to do a craniotomy to study human swallowing. We can use non-invasive techniques to induce activity in the brain. And one of these is magnetic stimulation or transcranial magnetic stimulation, TMS. It's been around for quite a long time, 30 or 40 years now, and is used quite a lot in the research of the kind of motor physiology in humans, but also therapeutically as well, for example, in depression. So in terms of swallowing, what we've been able to do is use this technique to study the corticopharyngeal pathways. One of the things we've used is a method to examine those pathways by inserting electrodes through a nasogastric type of tube where the electrodes are sitting in the pharynx. And then we can stimulate the cortex with our magnetic stimulator and induce activity in the brain, induce a descending volley, and measure a motor evoked potential, or MEP, which gives us a surrogate for that pathway. And here we see an example of a motor evoked potential. What you can see is that it's actually fairly short latency, so somewhere in the region of 8 to 10 milliseconds, but fairly easy to define. And obviously that gives us a sense of the integrity of the pathway. In the past, we've looked at, first of all, mapping out these various areas involved in swallowing. And what you can see here is just an example of a TMS study with the catheter that I mentioned earlier. And this lower quad of the 4 pictures shows you the kind of mapping that we might do, which each individual point in this matrix being stimulated, and we can record responses in the oral muscles, the pharynx, and the upper esophagus. And then this final lower quadrant to, I guess it'd be your right, shows the kind of color-coded mapping of a particular muscle. This is the upper esophagus pharynx. And what you can see here is that this individual shows quite marked lateralization, so that the area of activity for this individual was predominantly in their left cortex, and very little on the right, which we were a little bit surprised by. But when we repeated it 3 months later, it stayed about the same. So this lateralization phenomenon seems to be quite important, and I'll explain that in more detail. Just to say that when you map out all of the muscles, you get this somatotopic organization from the more caudolateral area that I mentioned, right through to a little bit more anterior and a little bit more medial. And what's interesting is that these areas seem to be not entirely typical of where you might expect swallowing to be. In our measures of the pharynx, it was much closer to the neck area of the homunculus rather than the facial area of the homunculus. So TMS is a good technique to study swallowing. There are other methods. fMRI is quite commonly used nowadays to study the physiology of human function in the brain. I'm not going to bore you with the method of BOLD, which hopefully you'll be familiar with, but it can be used to study swallowing function. Here's an example of a healthy subject who has had a swallowing study performed, and during the swallowing process, they had their fMRI taken, and you can see that there is activation in the right and the left sensory motor cortex. There's a little bit of activity. I think this is probably thalamus. Interestingly, when we delivered some stimulation to the throat, so using the catheter I showed you earlier, but acting as a stimulator rather than as a recorder, the activation in their swallowing system was significantly increased. If you induce additional flavors to swallowing, so the initial study I showed you was just with water. This is what happens when you look at saliva, chocolate milkshake, some sort of lemon drink, a popcorn flavored drink, and then water. What you can see here is that when you measure the amount of activity in the brain associated with swallowing, if you add flavor to the liquid taken, you get an increase in activation, which seems to be pretty similar, not, without it being specific to the different flavors involved. So the stronger the flavor, the greater the activation, the more areas of brain function that are recruited, which kind of, I think, makes sense. Interestingly, though, if you look at the effects of saliva swallowing versus water bolus swallowing, what you can see here is that there is some suggestion from this study from Rosemary Martino and Ruth Martin, was that when the individuals did saliva swallowing, there was a sense that there was more activity in the right lateral precentral gyrus, whereas when the individual did more water swallowing, so this is water swallowing, there seemed to be more activity in the left precentral areas, suggesting that there's compartmentalization, that certain functions regarding swallowing seem to activate areas in a more lateralized way, depending on the task involved, which I think is quite interesting and goes back to some of the lateralization theories. Furthermore, if you compare reflexive swallowing with volitional swallowing, and to induce reflexive swallowing, what these individuals did was to pass a tiny catheter through the nose into the throat, and then drip water through the catheter into the pharyngeal area to induce a reflexive swallow. And then secondary, got the same individuals to do a volitional swallow, where they were asked to do a pace swallow according to a particular paradigm, but that was volitional. What they then found was that when you compared volitional versus reflexive swallow, there seems to be differences in the activation patterns again. So reflexive swallowing seemed to activate more left cortical activity, whereas so volitional swallowing more so right. Interesting data. There is some evidence that when people have right-sided strokes, they may have more severe dysphagia. So that this may explain part of that phenomenon. We've had a chance to do a little bit of tractography as well. Perhaps some of you are familiar with this technique, a diffusion-weighted methodology that allows you to isolate white matter tracts within the brain and identify which bits of the brain are connected to other bits of the brain. It also gives you a measure of the degree of interconnectivity as well. And it obviously uses MR technologies basically this concept of diffusion anisotropy, which basically looks at the direction of travel of water molecules in axons, and obviously because the water molecules are trapped within the axonal fibers, they tend to go in a particular direction. So you get this kind of vector information, which allows you to determine those tracks in greater detail. This is tractography that we've done, and comparing that with fMRI. What you can see with the tractography data is that, and this is water swallowing, by the way, is that there's bilateral activity. This is group data, by the way. But interestingly, you can see the pathways going down into the brainstem. You can see the pathways going into the anterior cortex and the posterior cortex, and you can see this interconnectivity as well. You can just about make out this interconnectivity that exists. So we have a nice way of determining that the system is connected together, and obviously, as predicted, has inputs that go down towards the brainstem area. This fMRI just shows you that there's quite a lot of overlap of the swallowing area. So these colors represent activity with water, but also activity with tongue function and activity with saliva. And they seem to kind of overlap with each other with regards to those colors that I mentioned. So that's a summary of some of the physiological aspects of understanding the swallowing motor system. And particularly the brain control, specifically the higher centers. Let's move on to disease states, and I'll focus mainly on stroke because stroke is a particularly common cause of dysphagia in certainly the Western world. 50% of stroke victims will have swallowing abnormality, an increased risk of mortality, a greater risk of aspiration. A natural recovery will occur over time, but not predictably. And there are some difficulties around treatments in terms of both therapies, but also decisions around enteral feeding. And this creates challenges. We know that if you are a dysphagic aspirating stroke patient, you're much more likely to die. So you can see from this Kaplan-Meier curve of survival that at about 180 days, so 6 months, already there's a separation, and come up to 3 years, effectively over half of the patients who had aspiration will probably have passed away compared to non-aspirators, with a relative risk of death of 2.7 and a significantly greater amount of aspiration events. So quite important to understand why patients who have swallowing problems suffer, but why do some recover? And we've looked at this in studies in the past, taking patients with dysphagia and no dysphagia and tracking them over time to 3 months to see what happens to the brain representation. And what we found was that if you were a dysphagic patient, and we looked at the patients who recovered, who are in yellow, and we found that in the affected hemisphere, any changes there would not be predictive of recovery, and neither was it really the case in the non-dysphagic. If we look at the unaffected hemisphere, when we mapped out the area of activity in the brain for swallowing, in terms of the dysphagic patients who recovered, who again are in yellow, they tended to show an increase, whereas the ones who never recovered in red didn't change, and the non-dysphagic patients predictably didn't change either. So we had sort of fairly interesting evidence here that there's a compensatory process going on for the recovery. Here we see a pictorial example of this. When you look at this patient who had a small stroke, you can see here, and they were dysphagic at presentation, activity in the undamaged pathways was pretty small for their swallowing area. And as we mapped out their area over 3 months, and this patient was recovering, in fact, they made almost full recovery by 3 months, you can see there's a fairly significant increase in activity, predominantly in these undamaged pathways, with little or no changes in the damaged pathways. And so our argument was that this neuroplastic process, which is compensatory, was a form of reorganization, allowing undamaged pathways to become more useful in terms of driving swallowing response. So we were almost re-engaging these dormant pathways in order for the swallow system to restore, and that would make some sense, and to an extent explains why there is this sort of bilateral activity to help protect against damage in the brain. So we can see that there's recovery, and we can see that there's a reorganizational process going on. Can we work out what are the neurochemical drivers of this? This might be helpful for thinking about drug therapies in the future. One of the things we wanted to do was create a model for plasticity, which would allow us to then look at the neurochemical drivers. And one of the things we've been looking at is something called paired associative stimulation. And what it does is it combines combinations of two stimuli, which, using the principles of Hebbian plasticity, mean that if you combine two inputs together, you get a certain amount of information. But if you get that information to occur in a timely manner, so when you pair these two inputs so they're timed to come together, you will get a much bigger bang for your buck. And in order for us to do that, we have to know what the timing is between the two inputs are. And to know that, we used cerebral evoked potentials. So this is electrical activity in the brain, and following a stimulus, we can see when the activity demonstrates the evoked potential in the brain, and that gives us a timing. And looking at this, you know, the P1 activity was occurring within about 100 milliseconds of the stimulus. So our feeling was that if you put the timing around about 60 to 80 milliseconds, you should be able to kind of produce this paired associative stimulation activity in the brain. So we did this paired associative stimulation work. We looked at different timings. What we did was effectively combine a peripheral stimulus. So first of all, what we did was do some mapping to get some baseline cortical activity. Then we delivered an input peripherally, which was a pharyngeal stimulus, followed by a time interval, followed by a cortical stimulus. And we combined that for basically upwards of 30 minutes using a stimulus roughly every 20 seconds, a double stimulus every 20 seconds. So we did that for 30 minutes and looked at the response in the brain afterwards, and see whether there were some changes. And what we found was that when you delivered that stimulus with a 100 millisecond interstimulus interval, you got this really impressively large increase in activity in the swallowing regions of the brain, which we call cortical excitability. So this allowed us to then say, well, if this is related to induced plasticity, what are the drivers for this? What are the neurochemical drivers for this? So we could take that model and we can then try and look at the different chemical processes involved. And one of the ones we were particularly interested was glutamate, because it's an excitatory input, and we can measure that with a technique called MRS. So glutamate is a useful molecule in that it sits in vesicles, in terminal boutons of the neurons. And when a action potential arrives, those glutamate molecules are released, they cross the neuronal gap, and then they activate calcium and sodium channels, which then produce the action potential across the bouton. The glutamate is then mopped up, converted into glutamine, and then recycled. So with magnetic and resonance spectroscopy, we can look at this process using the fact that you have with associated proton changes, because depending on the chemical signature of the molecule, you get different radiofrequency pulse energy states, and so we can pick that up, and so you get this kind of printout with MRS, which depending on the peaks of the printout gives you an idea of the amount of a particular chemical. So you can see here you've got NAA, you've got glutamate, you've got creatine, choline, creatine. So we can use this as a marker of chemical activity. So we can take individuals, we can take a block of brain with MRS, study that, compare it with a control area, in this case the occipital cortex, and we can then deliver our plasticity-inducing intervention, in this case period associative stimulation, and then study the activity in the active area and in the control area, looking at glutamate changes. And this is what we found. What we found was that when they received the active paired associative stimulation, after 30 minutes to 60 minutes, there was actually a reduction in glutamate measurements compared to sham and compared to the occipital cortex. So we weren't exactly expecting this, but then started to realize that what was probably happening was that when you induce the plasticity, you're using up the glutamate, and then it's getting mopped up and taken away. So this reduction is probably a reflection of the mopping up effect, because the glutamate has been released and then taken away. So we think this tells us that glutamate plays a role, although it didn't quantify the release, it more quantified the kind of taking away. And this just shows you the change. So immediately after the paired associative stimulation, there was the greatest reduction, and then it started to recover over time, which is what you would expect. We did also do some work trying to establish whether we can also study something called GABA, which is an inhibitory neurotransmitter in the system, because inhibition and excitation often go together. And pretty much using a similar protocol, what we found was that there was actually a change in the in the GABA measurements. In this case, the GABA went down. And that would kind of make sense, because less GABA would mean more excitation. The changes were very subtle, so it looks like whilst there is a glutamatergic and GABAergic related effect here, probably the glutamatergic phenomenon is stronger than the GABAergic phenomenon. So that's the neurochemical processes. Now we're moving on to neurostimulation, which is an area of particular interest to me in terms of thinking about rehabilitating the swallow system when it's damaged, particularly after neural injury and things like stroke and other forms of brain injury. And we've looked at a number of techniques: pharyngeal stimulation, RTMS, which is repetitive TMS, and more recently cerebellar stimulation. I've talked a bit about pharyngeal stimulation already. This is where we stimulate the pharynx using the same catheter I showed you that we record from. So instead of recording, we can hook it up to a stimulator box and deliver stimulation directly to the pharynx. And we think that then has effects in the central nervous system by adding a significant sensory afferent activity to drive changes in the brain. In some very early studies a few years ago, what we did was we delivered this stimulation using a 10 Hertz paradigm for 10 minutes and measured activity in the brain before and after, and we found that there was an increase in the swallowing area following pharyngeal stimulation, which lasted about 30 minutes. We've then looked at frequency specificity and found that 5 hertz was much more effective than 10 hertz. And if you do very high frequency, you actually got inhibition. And we also looked at it in stroke patients, where we looked at the effects of the pharyngeal stimulation, in this case 10 hertz, both in the healthy brain but in the stroke brain. And in the healthy brain, as before, when we delivered the 10 hertz, the 5 hertz for 10 minutes, in the period afterwards, there was an increase in activity bilaterally. Whereas in the stroke subject, what we found was that following the 10 minutes of 5 hertz stimulation, in the period that's immediately thereafter, again, there was bilateral activity, but you can see there was a much stronger activity in what was this individual's undamaged pathway. So the undamaged system was much more likely to respond to the stimulation. We also found that when we looked at the physiological changes in the swallow using videofluoroscopy, and these are timings and aspiration amounts. So in this case, got pharyngeal transits or response time and aspiration scores following stimulation compared to sham in these 16 or so patients who were randomized. The transit time and swallow response time both reduced, which is good, and the aspiration score also reduced, which is good. So this suggests that short-term stimulation with pharyngeal stimulation was providing some beneficial effects in both the cortical changes, but also the swallowing physiological changes. This hasn't come out very well. It's a correlation of the amount of cortical activity induced by the stimulation in those stroke patients correlated with the amount of aspiration improvement. So the higher the score on the what would be the y-axis, the better the aspiration. And what you can see here is as we measured cortical excitability and correlated it with reduced aspiration, there was a correlation. So the greater you could induce the activity in the brain, the greater you could induce the excitability in the swallowing systems, the better the outcome in terms of the aspiration scores. So a suggestion that there may be some causality between brain excitability in this model and aspiration improvement and swallowing improvement. What about RTMS, which is repetitive magnetic stimulation? So these systems are commercially available. This is quite an old system, but there's much newer systems around now. It delivers various frequencies over short periods of time to the brain. We've looked at, again, some frequency effects where we delivered different frequencies of RTMS and looked at the motor potentials in the pharynx and in the hand as a control. And we found that when you compare 5 hertz with, say, sham or the hand, the 5 hertz was able to induce increases in activity, which you didn't see with sham and you didn't see with hand. So this is applying the stimulation directly to the pharyngeal cortex over the scalp. And you can see here when we looked at different frequencies, 5 hertz, this magic 5 hertz seemed to induce the greatest changes compared to 10 hertz, 1 hertz, and sham. So 5 hertz looked like it was quite a good frequency to use. We then thought, well, we could apply this in stroke patients, but maybe before we do that, because RTMS does have some risks associated with inducing seizures, we should maybe try and look at it in models of swallowing dysfunction in health. And in order to do that, you can use something called a virtual lesion. So a virtual lesion is a temporary experimental disruption of cerebral function, short-term targeted, and can reduce functionality for a very short time. Typically in animals, it's done use cooling, but in RTMS world, you could use it using a low frequency stimulation, in other words, 1 hertz. So what you can do is you can take an individual, you can do some baseline recordings, and you can also do some behavioral measurements, in this case, speed of swallow. Then you can induce a virtual lesion in one side of the brain, which was done using a 1 hertz 10-minute paradigm, 600 pulses. And then what you could then do is look to see what happens to those cortical changes and behavioral changes in the period thereafter to see if it's had an impact on that. And what we found was that, yes, you could certainly reduce the brain activity with the virtual lesion. So you can see the MEPs shrinking here. What was also interesting was that there were consistent inhibitory changes, which lasted about 45 minutes. So this seemed to be a nice window of opportunity to study the virtual lesion. And when we looked at the behavioral measure, which in this case was a time to swallow from a peripheral stimulus to the hand, so we delivered the peripheral stimulus to the hand, and then we measured the time it took for the individual to swallow, which we call the swallow response time. And we looked to see what happened to that. When we looked at the virtual lesion, we could see that it was changing. So we got changes in the behavior in the same time field as that virtual lesion. So we had a model where we could study cortical excitation and behavior using the virtual lesion. So the next question is, can we reverse that virtual lesion with the RTMS that I showed you earlier, the 5 Hertz RTMS? The idea was that we could take the 5 Hertz and somehow reverse the 1 Hertz virtual lesion effects as a model for using it in stroke patients. And so here's the idea. Took some healthy subjects. We did some baseline measurements of both the cortex and the behavior. We then applied the virtual lesion, and then they were randomized to real 5 Hertz excitatory stimulation or sham 5 Hertz stimulation, and we looked at the changes in the period thereafter. So here we see the sham intervention here. So this is the sham 5 Hertz, and you can see that when we apply the virtual lesion, the MEPs shrink. So that makes sense. When we look at the real, and again we applied the virtual lesion, we were able to reverse that inhibitory effect. So actually blocked the virtual lesion. And here we just see it again in graphic form with the sham, the inhibition was maintained. With the real, the inhibition was reversed. That was the side that was virtual lesioned. Actually, we even got a little bit of changes in the unvirtual lesion hemisphere as well. And what about the behavior? Well, what we found was with the sham, the behavior was, as expected, reduced, worsened, but with the real, we were able to improve the behavior. So we reversed that poor performance. These changes, by the way, are pretty subtle. They require equipment that can measure this. So this wouldn't translate directly into somebody sort of aspirating. So you can't induce aspiration with the virtual lesion in a healthy subject. So you don't need to worry about that. So does RTMS 5 Hertz work in stroke? This is a study that was done in Korea, and they took the 5 Hertz and they delivered it to about 20 different patients, randomized to active or sham. These were subacute stroke patients, and they received once a day 5 Hertz for 10 days, delivered to the undamaged pathways, the undamaged swallowing system. And they were able to find that in the active arm, in the period of 1 month, that their swallowing measurement, which in this case was a form of videofluoroscopy scoring, looking aspiration, it was better. So the lower the score, the better the swallow. In the sham arm, it was more or less flat. There wasn't much change. So looks like the RTMS 5 Hertz delivered this way is not bad for swallowing function. So what we wanted to understand was what happens when you compare 1 Hertz and 5 Hertz in terms of their effects. And as you can see here, what we found was that 1 Hertz was inhibitory, as I've said already. 5 Hertz, 250 pulses, was excitatory, generally speaking. However, what's interesting is if you look at this over a really much larger group of individuals, you find that you get a much more messy outcome. So when we looked at lots and lots of individuals over time, we found that the 1 Hertz paradigm can be inhibitory, but not always. And equally, the 5 hertz paradigm can be excitatory, but not always. So this variability of response started to worry us, and we were thinking, well, why is it so variable? And we asked the question, could it be related to genetics? So this led us to start to study some of the genetics associated with the cortical variability to RTMS. And so we took about 15 or 20 different genes, which were either involved in swallowing or involved in neuroplasticity or excitability. And you can see a few examples of them here: BDNF, DRD2, COMT. Some of these are involved in dopaminergic function, etc. And we looked to see if we could work out, based on this single nucleotide polymorphisms, whether you could predict that responsivity to stimulation. First of all, we had to define the phenotypes, and what we found was that there were basically 3 types of phenotypes with RTMS. There's the group who go in the right direction, so it's excitation or inhibition. There's a group that go in the wrong direction, again, excitation or inhibition. And there's a group that don't respond at all. So we had these 3 groups. And then what we then decided to do was look to see if you could determine, based on those 3 groups, whether any of these genes were likely to make a difference. And what we found was that 2 genes in particular were quite important. One was COMT, which was more relevant in the 1 hertz paradigm, and the other was DRD2, which seemed to be more relevant in the 5 hertz paradigm. And when I show you this slide here, what you can see is that if you were a non-carrier of the COMT gene, you were much more likely to be a responder to the 1 hertz paradigm. By contrast, if you were a non-carrier of the DRD2 gene, you were much more likely to be a responder to the 5 hertz intervention. So your genetic makeup seemed to play a role in this variability and responsiveness, depending on if you're a carrier or non-carrier of a couple of genes, and probably more. We just weren't able to study them all because the study would have become too complicated. But what this does lead to is the idea that there could be some form of precision medicine in the future, where you could perhaps utilize the genetic makeup of an individual to determine whether they're going to respond to your treatment or not. So getting close to the end now, cerebellar stimulation is a newer technique that's been tried as an important consideration in the idea that these other areas of the brain may have roles in terms of rehabilitation. When you look at swallowing and neuroanatomy, and this is a PET study, what is noticeable is that, of course, you get the activity in the sensory-motor cortex. You also get activity in the insula. But what's interesting is you get quite marked activity in the brainstem and in the cerebellum. So brainstem activation, you don't often see this with fMRI because the fMRI doesn't always cover the whole brain. And the cerebellum, marked activity in the cerebellum. So suggests that there must be a role for the cerebellum. So what happened if you stimulated cerebellum as a kind of intervention? You can do that with the TMS, just repositioning the coil over the occipital area. And you can actually target the cerebellum using neuronavigation. So you can neuronavigate where the coil is positioned in order to ensure that you're over the cerebellum. What's interesting is if you stimulate the cerebellum relatively high intensity, you can actually invoke a motor response in the pharynx. So this is the cortical response to cortical stimulation. But what you can see below is left cerebellar stimulation and right cerebellar stimulation. You can see the morphology is slightly different. This is midline cerebellum, so smaller. So there are somehow these pathways which you can activate when you stimulate the cerebellum. And what we decided to do was to do another paired associative type of study where we paired the cerebellar stimulation with cortical. So we initially delivered the cerebellar stimulation, and then in a period thereafter, we delivered the cortical stimulus. And what we found was that the cerebellar stimulation was able to massively facilitate the cortical response. when the interval was about 50 milliseconds. And this was a sort of huge increase of nearly 300%. So quite dramatic compared to anything else that we have studied before. There was some suggestion that the cerebral stimulation was acting not just through a cortical loop, but possibly through a brainstem effect, because we've also got shortening of latency of the motor potential, would suggest that the motor neuron may be activated. Though that was just using single pulses. What happens if you deliver repetitive stimulation to the cerebellum? What you can see here is we looked at different frequencies, 1 hertz, 5 hertz, 10 hertz, 20 hertz, tried to maintain the same level of energy. And what we found was that in contrast to cortical stimulation, the best frequency for exciting the system was 10 hertz cerebellar stimulation. 10 hertz cerebellar stimulation was able to induce sustained changes in the cortical pathways compared to these other frequencies. And we found that if you delivered something in the order of 250 pulses, that was just as good as delivering 500 pulses and much better than delivering 50 pulses or sham. So we had a recipe which was 10 hertz, 250 pulses. We then took a patient who had a posterior fossa stroke. You can see here that they damaged the cerebellum, but also leading into the lateral medullary area, and they were aspirating. And we decided to do a study where we would deliver the cerebellar stimulation and look at both the cortical effects and also the swallowing effects. And what was interesting was that, and this is kind of like a crossover study, so they had one intervention followed by another. And what we found was that with the active cerebellar stimulation, we could induce increase in activity in the brain, and we could also reduce the amount of aspiration. This is a single case study suggesting there may be a role for cerebral stimulation, particularly in these difficult to manage posterior fossa strokes who have quite severe dysphagia usually. Now, I've talked already about the genes and plasticity. One of the other genes of interest to us was BDNF. And what was interesting about BDNF was that it does look like that it may play a role in modifying responsiveness to neuroplasticity. And BDNF is recognized to play an important role in synaptic function, in learning, brain development, and there are effectively recognized single nucleotide polymorphisms, in particular the MET-VAL polymorphism, which tends to distribute itself such that the VAL polymorphism is probably twice as common as the MET polymorphism, particularly in Western countries, whereas if you go more towards Asia, places like China, the MET allele tends to be more dominant. So that's interesting. A study by Jeff Klein in 2006 suggested that depending on your polymorphism, you could get more plasticity following a hand training task compared to the MET allele. So the VAL subjects were more likely to have greater post-training activity in the brain compared to the MET allele. We were interested in this to pharyngeal stimulation, which I mentioned already was a cortical plasticity inducer. And what was interesting was that when we looked at the same phenomenon and looked at the effects of BDNF, we found very similar findings. The VAL polymorphism individuals produced a much greater level of pharyngeal stimulation induced activity compared to the MET allele, which were almost flat. So VAL excited, the MET, either VAL-MET or MET-MET, were flat line. So we asked the question, could this translate into something else? Could this be a way of, just like with the other genetic studies we've done, a way of determining who might respond better to pharyngeal stimulation than those who won't, depending simply on this BDNF gene. Interesting aspect to this. Is this the future? It's hard to say, but I think we are already doing genetic studies in stroke for responsiveness to clopidogrel, for example. So I don't know. This could be a new way forward, but it obviously needs more research. So I'm going to summarize. I've talked a lot about the swallowing system. I've told you it's a bilateral motor function, but it has lateralization, and this lateralization is important in relation to recovery mechanisms following stroke, particularly in relation to the reorganization that occurs in the unaffected, undamaged side of the brain. I've talked a bit about the neurochemical mediators associated with plasticity in the swallowing system, and suggested that glutamate and GABA play roles. And I've shown you that neurostimulation in the form of pharyngeal stimulation, RTMS, cerebellar stimulation, they all seem to potentially hold promise for application as clinical tools to rehabilitate swallowing following neurogenic dysphagia. In this case, predominantly the studies were in stroke, but potentially in other forms of neurogenic dysphagia, such as traumatic brain injury, multiple sclerosis, and others. But we obviously need more clinical data to support that. And then finally, I've talked a bit about the genetic influences, which are likely to play an important role in determining this response to neurostimulation, and given you some insights into the future and the idea that maybe precision medicine may be the future for dysphagia therapies. So I'd like to just finish there, thanking researchers in our team in the past and in the present who have been involved in all of this research. I'll also shout out to Professor Rothwell, who was retired now, but part of the Institute of Neurology, Human Movement Balance Unit, who was one of the instrumentors of some of the TMS work we've done, very influential. This is a photo in Göttingen at one of the TMS, TDCS conferences that we went to a few years ago. So I'd like to thank the audience for listening. Happy to take any virtual questions if there are any. Thank you.